This week we'll talk about, continue our discussion of the nervous system, but we'll kind of veer off from what we've been talking about with central and peripheral and talk more about special senses. That's going to be like hearing, tasting, balance, vision, things like that. And then we'll also spend some time talking about the autonomic nervous system, although that will be quite a short lecture as far as the anatomy goes. When we get to physiology, we'll spend more time talking about the function of the special senses and the function of the autonomic nervous system, and that will take a bit more time. So you'll find both of these lectures to be fairly short compared to our usual ones. So let's look at the anatomy of the special senses. We'll start with the olfaction, which is the physiological term for smelling. So the olfactory system is quite simple, and I think we'll describe it all here on one or two slides. But I want you to follow kind of the flow of information. So when we think of our special senses, what we're really talking about are ways that our bodies kind of experience the world around us and relay that external environment to the brain so that the brain can interpret what it is that we're experiencing. So if we're talking about olfaction, which is smell, we're talking about really chemicals that are in the air around us. These chemicals might come from food, they might come from flowers or trees or perfume or rotting and decaying debris. We get these molecules in the air around us from multiple sources, and we have to basically translate these molecules into a scent that is recognizable. And so I want you to follow kind of the transmission of that signal from molecule on receptor to interpretation in the cerebral cortex. So we'll talk about just here briefly how that signal gets sent from the nose to the brain. So first of all, the first step is that these molecules which are in the air around us, let's just take, for example, bacon, because you guys know how fond I am of bacon. So let's just assume that you're in a kitchen and someone is cooking bacon. How does your brain know that bacon is being cooked? Well, from the smell standpoint, those molecules that are going into the air as the bacon is cooked will eventually make their way to the air surrounding your nose. And then when you take in a breath, those molecules become dissolved in the mucus that is in your nose. That's one of the functions of mucus. As those molecules get dissolved, they are then able to land on and bind to receptors that are in your nose. Now, those receptors are not themselves part of the nervous system. They're part of the epithelial cells of the nose. But what will happen is once the molecules bind to those cells, those receptors, the receptor will then trigger an electric signal that goes eventually to your brain. So once the molecule dissolves, binds to the receptor will send a signal to the olfactory nerve that it's attached to. Now those olfactory nerves, and there's several of them, will go through the cribriform plate. You remember when you were learning the bones of the skull, and we looked at the ethmoid bone, and on the if you kind of did a superior view of the inferior part of the skull, you saw that cribriform plate, and it had little tiny holes in it, if you remember. Well, those holes are at least in part for these olfactory nerves to go through, to go from the nose up into the area of the brain, up into the area of the skull. They need to have an access point. They need to have an entry point. And that entry point is through the cribriform plate, through those holes. So the olfactory nerves will go up through the cribriform plate and will kind of coalesce together into the olfactory bulb, and will send their signal from olfactory nerve to olfactory bulb. And you guys have already looked at the brains in a lab, and you remember those olfactory bulbs were actually quite prominent on the undersurface of the brain. They're pretty easy to see. They're quite large. So we go from molecule in the air to olfactory receptor to olfactory nerve to olfactory bulb. And then that olfactory bulb then sends its tracks down the its axons down the olfactory tract and eventually ends up in the central nervous system. And what's interesting about smell is that it actually sends the signal from those molecules to multiple areas of the brain. So, of course, when it sends the signals to the olfactory centers of the cerebral cortex, you'll remember the cerebral cortex is kind of where we have conscious awareness of whatever we're experiencing. So, for example, conscious awareness of pain if you step on a tack, or conscious awareness of heat if you touch a flame. So here you're going to have conscious awareness of a scent. And because you have smelled bacon in the past, your brain knows what bacon smells like. And so every time that molecule dissolves and gets carried to the brain, that signal gets carried to the brain, your brain will interpret that as bacon. But more than just going to the cerebral cortex for interpretation of smell, smell actually sends part of the signal goes to the areas of memory in the brain and the areas of emotion in the brain. And so what we've found is that smell can actually be a powerful key to unlock memories. I'll give you an example from my own life of kind of the emotional and memory aspect of smell. So I think I've told you guys that I spent several years in Africa. And when we were away our first time, we were gone for 2.5 years before we came back to America. And I didn't realize how much I enjoyed the fall season, September, October especially, and just kind of all that goes along with that. Yes, the cool weather, and yes, the leaves changing color, and the smells and the sounds, but also the smell of pumpkin. You don't realize until you leave the country for a couple of years how integrated the smell of pumpkin is to that whole fall season. And so we had been away, and we had been living in a dry and hot place that really had no seasons. Of course, being in Africa, they didn't have the same cultural ideas about fall as we had. So there was no pumpkin spice latte, there was no pumpkin muffins, there was no anything that had to do with the fall. So when we did finally come home after 2.5 years, I was walking through Target, and as soon as I walked in the door, at least in the Target near us in Liberty, there's a Starbucks right there near the door. And as I walked in the door, I smelled pumpkin spice latte being made. And I looked around, and of course there was pumpkin spice everything, and there were the leaves of the season hanging around in decoration of the store. But when I smelled that pumpkin spice, I actually got tears in my eyes. It was like tears of joy, remembering how much I enjoyed the fall season. I enjoy pumpkin spice things, how much I enjoy the leaves changing. That whole season was wrapped up in a smell, in a scent. And that scent triggered all of those memories, and those memories came back in such a flood that it actually brought tears to my eyes. So smell can often be used actually to jog people's memory, or sometimes you'll find yourself having an emotional response to smell. And that's because not only do the fibers from our sense of smell go to the cerebral cortex for interpretation, but they also go to the emotion and memory centers as well. Okay, the next special sense that's also pretty simple to describe is gustation, which is a physiological term for taste. So most of you are aware that your tongue has numerous taste buds. In fact, and so there's numerous taste buds on the tongue, but each taste bud is actually composed of 40 to 100 gustatory epithelial cells. So again, these taste receptor cells are not actually part of the nervous system. They're actually epithelial cells, but they are going to trigger the signal that goes into the nervous system and eventually to the cerebral cortex so that you can interpret what it is that you're tasting. Okay, the same idea here that we had in olfaction is that you need to have these molecules that you're tasting. So when you put something in your mouth, again, let's talk about bacon. You put a piece of bacon in your mouth, there are multiple molecules within that piece of bacon, and each of those molecules are going to stimulate a different type of taste receptor. So of course there's salty in there. There may be a little bit of bitterness, especially if you have overcooked the bacon a little bit. So there are multiple flavors going on, and each of the molecules that create those flavors will dissolve in the saliva. That's one of the functions of saliva, is to help us taste by dissolving these molecules. And those dissolved molecules will land on their respective taste receptors. Once they've bound to those receptors will then signal the nerves that will carry the signal to the brain. And those nerves which carry that signal are listed here. They are 3 of the cranial nerves, cranial nerve 7, 9, and 10. And it depends on which part of the tongue that taste receptor is located in. So, for example, if you look at the facial nerve, cranial nerve 7, which we've learned is the nerve that innervates most of the muscles of the face, it also carries taste sensation from what we call the anterior 2/3 of the tongue. So the front 2/3 of the tongue on each side will be carried by each side's facial nerve, cranial nerve 7. The posterior 1/3 will be carried by the glossopharyngeal nerve you can see there. And the vagus nerve carries a little bit of flavor kind of from the back of the throat, more from the oropharynx area will be carried by the vagus nerve. So you see those 3 nerves will then take the signal from the taste receptors in the tongue up to the brain. And you can see here that they're going to stop over at a couple of places, but ultimately they're going to land on the gustatory cortex, which is kind of tucked away there in what we call the insula, which you don't really have to know. Just for the sake of this course, just know about taste receptors and know about the need for those molecules to dissolve, land on the receptors, and the signal is sent via these 3 cranial nerves. So most of us have learned, I remember I learned, in grade school or wherever, that there were 4 basic tastes. There was sweet, sour, salty, and bitter, and most of you probably learned the same. Some years ago, I became a little bit obsessed with these food shows on the Food Network, and partly because we were in Africa and we weren't able to get, a great variety of food, and so I would kind of live vicariously through these shows on the Food Network that we would download and watch, or we would get CDs and we would watch them, or DVDs and we would watch them. And I heard people talking about this 5th taste called umami, and I thought that it was just these kind of food people kind of trying to come up with something new. Well, apparently it has actually been proven that there is now at least a 5th taste. So we still have our 4 that we've all grown up with: salty, sour, sweet, and bitter. But there is a 5th flavor that's been identified called umami. And what I mean by proven is we have actually found a taste receptor that is specific for the flavor that we call umami. Now, what causes umami is the molecule glutamate. And so it's actually when glutamate lands on this receptor, it causes an electrical signal to be sent to the brain, and we experience a very unique flavor. One of the foods that causes umami is bacon, for example. There is a fair amount of glutamate in bacon, and it's one of the reasons that we think bacon is so unique and so tasty. And so not only will salt receptors be activated by bacon and maybe some bitter receptors, but also these umami receptors are going to be activated by things like bacon. You can see there's some other foods listed here. We've got bacon, we've got cheeses like Parmesan cheese in particular, mushrooms, for example, things like ketchup, for example, are actually full of umami as well. A lot of things that come from the sea are also full of glutamate. Some of the seaweeds, for example, and some of the fish that come from the sea. So a lot of Asian food is kind of heavy on the umami. Monosodium glutamate, MSG, obviously has glutamate in it as well, and opens those receptors. So glutamate is the 5th flavor that has been proven. There are also some research being done on a couple of other taste receptors for fat and for water, and they are still in the process of kind of determining if they are separate receptors or not. But you may find in the future, if you kind of keep looking at this idea of taste receptors, you may find that we have even more than 5. You may find that fat and maybe even water are added in the future as separate taste receptors. But for now, we know for sure that they're salty, sour, sweet, bitter, and umami is the newest one. Okay, let's move on to the ear. In the ear, we're going to look at the anatomy starting from the outside of the ear, and then we're going to move in to the middle ear. From the middle ear, we'll move into the inner ear. And there are anatomical structures that you will have to learn in each of those 3 sections: external, middle, and inner ear. So let's start with the external ear. We call basically the part of the external ear that you can see with the naked eye, that whole floppy part of your ear that hangs off the side of your head, we call that the auricle. Now, attached to the auricle, there is another a separate structure that we call the tragus. If you look at your ear and even reach up and touch your ear, pretty much all that you're touching there, the kind of rounded portion of your ear, that's all the auricle. And then, of course, you have the ear lobe, which we know. If you come straight up from the ear lobe and kind of inward towards your towards the mandible, so come up from your lobe and then go in towards your face, towards the mandible, you'll find kind of a floppy cartilage there that you can kind of push in, and it would plug up your ear. It would kind of muffle the sound, and it would cover the external acoustic meatus. And we call that little piece of cartilage, we call that the tragus. And if you're having trouble visualizing that when I meet with you in lab, grab me and I'll point it out to you. But it's that part of the ear that's closest to the mandible that you can kind of push, and you can close off the external acoustic meatus. So we call that the tragus. The external acoustic meatus is just that hole, the opening on the outside of your ear, and that leads into the external ear canal, which would be this part. So the meatus would be the opening there. The tragus has been cut away on this picture, so you can't really see it. But the external ear canal would then carry sound waves into your ear until they reach the tympanic membrane. So the tympanic membrane, which is basically a flap of skin, it's very similar in makeup, it's epithelial tissue, that divides the external ear from the middle ear. So the tympanic membrane is kind of the divider between external and middle ear. So really only a few external ear components here for you to learn: auricle, tragus, external acoustic meatus, external ear canal, and tympanic membrane. Okay, as we move medial to the tympanic membrane, we will enter the cavity known as the middle ear. So again, we'll start with the tympanic membrane. From the tympanic membrane, you see the next structure are these 3 bones that we call the ossicles. So together they're called ossicles, and they're the smallest bones in the body. The first one is the malleus, and then the incus, and then the stapes. You may have learned hammer, anvil, and stirrup or something like that in your early years of education. Anatomically, they're called the malleus. That's the largest of the 3 bones. Then the incus, and then the stapes is the very small, kind of horseshoe-shaped bone at the end. So those are the 3 ossicles. You'll need to learn each of them. Excuse me. There is then something called the chordae tympani, which is really a branch of cranial nerve 7. And you can see it here in the picture. It's this yellow branch there. And I pointed out to you just for a couple of reasons. One, it's there in the middle ear, and if something goes wrong in the middle ear, you may have some trouble with that branch of the nerve. But I also pointed out because if you're looking through the external ear canal with an otoscope to kind of look at the tympanic membrane, what you will see is this part of the malleus that's touching. You'll see that through the tympanic membrane because the tympanic membrane is typically transparent. And one of the structures you may also see is the chorda tympani. you may actually see that nerve crossing in the background. So it becomes a landmark when you're doing an ear exam. Okay, then there's a couple of muscles, the tensor tympani and the stapedius. The tensor tympani is kind of the larger one. The stapedius is a smaller one here. And I'm not going to ask you to identify those, but I do want you to understand why they are there. Why are there muscles in the middle ear? What's their purpose? Why should there even be muscles there? And I find this quite fascinating, actually. So those muscles are there for a very specific function. Let's say you go to a rock concert and the noise gets very loud. Those sound waves, as they come into your external ear canal, they will begin to cause the tympanic membrane to vibrate. And the vibration of the tympanic membrane will then cause the vibration of these ossicles. Well, the amount of vibration that happens is proportionate to the loudness of the sound that's entering the ear canal. So imagine if you have very loud noise, you're going to have a very large disturbance in the tympanic membrane and a very large disturbance in the ossicles. Those bones will be moving very strongly. And you could actually damage those ossicles by making them move too much, especially if it's done repeatedly. So the stapedius and the tensor tympani especially will actually contract when the noise level gets too loud. And when they contract, they kind of pull on this tympanic, on the ossicles, and they kind of hold the ossicles in place so that they don't move back and forth quite as much in response to the loud noise. And that's a protective measure for those ossicles. It keeps them from being damaged. There's also an auditory tube, or what we often call the eustachian tube, and that's this part here. And that's important because the eustachian tube, or the auditory tube, actually goes from the middle ear to the back of your throat, to your oropharynx. And it kind of provides a thoroughfare from the middle ear to the back of the throat. And that's good for a couple of reasons. One would be if you ever got fluid in the back of your middle ear cavity, you would want, the fluid couldn't come out this way because the tympanic membrane separates the external and middle ears. So how would you get rid of that fluid? Well, it turns out that fluid will come out through the eustachian tube, through the auditory tube. The other thing that's interesting about this tube is that it helps to equalize the pressure in that middle ear as well. Sometimes you can build up a negative pressure there, and that will affect hearing. So that eustachian tube functions to kind of equalize the air pressure with the external environment and the middle ear cavity. And you've all experienced this. If you've been up in an airplane, or you've been driving and gone up the side of a mountain, for example, you will feel your ears popping, right? You'll feel your ears, you'll kind of lose hearing temporarily. Not lose it, but it becomes diminished as you go up in elevation. And you've all opened your eustachian tube. Maybe you didn't know that's what you were doing, but you've all opened your jaw very wide, opened your mouth very wide to try and pop your ears, or you've chewed gum, or you've swallowed. All of those actions help to open the eustachian tube and help to equalize the air pressure in the middle ear cavity and the external environment. Often when kids get middle ear infections, for example, what happens is that eustachian tube gets inflamed and it closes off in response to the virus that you have, the cold virus that you have. Either the tissue in your oropharynx gets inflamed and shuts off the tube, or the tissue of the tube or of the middle ear gets inflamed. At any rate, the tube stops functioning and fluid builds up in the middle ear. Once fluid builds up, then bacteria like to grow in there, and so it can be the cause of ear infections. So that eustachian tube is kind of an important structure. Then there are two windows. There is the round window and the oval window. The oval window is the part of the back of the middle ear cavity, and you can't see it super well in the picture because the tensor tympani is kind of covering it, but it's in this area here. And it's the area that the stapes is attached to. So as sound waves enter the ear canal and cause the tympanic membrane to vibrate, that causes the ossicles to vibrate, and the stapes, being the last of the ossicles, is attached to the oval window, and it causes the oval window to oscillate back and forth, to vibrate. And that vibration leads to fluid waves in the inner ear that eventually is interpreted as sound. And we'll talk more about that when we get to physiology. So the oval window is attached to the stapes and actually transmits the sound waves. The round window is here on the other side. If you can imagine, you see here in the picture, there's the inner ear. If you can imagine the sound waves going, through the cochlea here, well, they have to have a way of escaping eventually so that they don't just keep bouncing around the inner ear over and over. And the way that they eventually escape is they come out through the round window. And the round window is then can then kind of transmit those waves to the middle ear and eventually out through the eustachian tube. Okay, so that brings us then to the inner ear. Now, the inner ear or internal ear has two primary functions. One is for balance and one is for hearing. And we'll kind of talk about the two different parts of the inner ear based on those two functions. So if we look at this part here, the part that kind of looks like the snail, that's the cochlea. And the cochlea is what I was just talking about. It's connected to the oval window, which is connected to the stapes, which helps transmit sound waves. So the cochlea is really the hearing organ of the body. And again, we'll talk about that more in physiology. So it transmits those waves that went from air to bone, and then in the cochlea they go to fluid, and they become fluid waves, and those fluid waves eventually send signals to the brain that you are hearing. So the cochlea is kind of the hearing center. And then you have what we can call the labyrinth. There's a membranous labyrinth and a bony labyrinth, and that's just this portion up here that kind of look like maybe rabbit ears or however you want to look at them. And this is where we're going to get interpretation of balance, of where our head is in the world around us. Are we leaning forward? Are we leaning backwards? Are we spinning in a circle? Are we accelerating forward? Are we decelerating? All of that information is going to be carried out in this portion of the middle ear. So that portion, the labyrinth, has two primary sections as well. There's this kind of middle section that is not loopy, and then there are all of the loops. There are three of them. So let's talk about each of them separately. So the part that's not in the loops is called the vestibule, and that's how we sense linear movement. We're talking straight up and straight down, and straight forward and straight back. So this would be accelerating and decelerating forward and backwards or up and down. That's going to be sensed in this vestibule area of the inner ear. And the vestibule itself is composed of two areas called the utricle and the saccule. And one of them is for up and down movement, and one of them is for forward and back movement. Okay, then you have these canals, these circles, these loops. We call them semicircular canals, and they are used to sense rotational movement. So are you spinning? Are you leaning off to one side? That kind of rotational movement is coded or transmitted from the semicircular canals. Now, all of that information, all of the balance information, whether it's from the vestibule or the semicircular canals, is going to be transmitted through what we call the vestibular nerve. So it comes from that term vestibule. The vestibular nerve will carry all of the balance information, whereas the cochlear nerve will carry all of the hearing information from the cochlea. Eventually, the vestibular nerve and the cochlear nerve join up to become cranial nerve number 8, which we call the vestibulocochlear nerve. Okay, there is some fluid running through both the labyrinth and the cochlea, and it's actually that fluid that gets moved either by sound waves or by rotational or decelerating movements. And it's the movement of the fluid that eventually activates receptors that eventually sends a signal to the nerve, which eventually goes to the brain so that we can interpret sound waves or movement. And so there's two kinds of fluid, endolymph, and perilymph. You're not going to have to be able to distinguish between them, but we'll talk more about that in physiology. So it's good to learn those terms so that when you get to physiology, you're already ahead of the game. All right, so the vestibulocochlear nerve I mentioned is kind of the cranial nerve number 8 that's formed from those two separate nerves, one coming from the labyrinth and one coming from the cochlea. They will eventually come together as one nerve, and they will send signals to two primary locations. One is going to be the brain stem, and in the brain stem is going to use that information about position and about sound to help coordinate reflexes. For example, if you hear a sound, there will be a reflex where your head and your eyes will turn to the sound. Now, that's not initially something that you think about. That's a reflex. That's done unconsciously. That's why it happens down in the lower part of the brain, in the brainstem. Remember, things that happen in the brainstem are not conscious. They are unconscious, right? Like breathing, like your heart rate, like your blood pressure. These are not conscious activities. These are unconscious. So part of the information goes to the brainstem to help coordinate eye movements, for example, body movements. If you feel like you're tipping over backwards from a chair, for example, your balance centers will sense that change in location, and you will have a reflexive movement that helps correct your position so that you don't fall over. That's not conscious. That's done unconsciously through the brainstem. Okay, then of course, the information also gets sent to the cerebral cortex. And in the cerebral cortex, you become consciously aware of where you are in your environment, and consciously aware of and even interpret sound waves. So, for example, when you hear the sound of your father on the phone, you not only know that it's the sound of a man talking, but you know exactly who that man is because you have heard that voice before. And those memories are used to interpret that same pitch, that same cadence of voice, that same accent, even word choices that are used. It's all stored in a particular to represent a particular person, so that when you hear those sound waves, you know exactly who's talking. That requires higher brain function, right? Interpretation of sound is going to require the cerebral cortex. That's where those higher centers are located. So it goes to both areas. Okay, let's look at the eye. We'll start with kind of the surface anatomy of the eye, and then we'll start looking behind what you can see with the naked eye, what is deeper in the eye, and we'll identify some structures back there as well. So when we start with the surface anatomy, we're just looking at the eyeball, right? We're saying, what can you see if you just stare at your neighbor's eyeball? Okay, well, there are a few things that we can see, and we label these as, we give these areas of the eye particular names so that when we're talking to each other about a problem, we want to know, well, where is the problem? So, for example, is the problem in the medial angle, in this area of the eye? Or maybe it's in the lateral angle, right? If I want to know where the scratch on the eye is, or if I want to know where the foreign body is, or if I want to know, where the broken blood vessel is, I need to be able to describe that in a way that everybody understands. So we start giving different parts of the eye their own name so that we can help describe where the problem is. We can also talk about the palpebral fissure. Now, this would be the area between the two eyelids, the upper and the lower eyelid, is called the palpebral fissure. The pupil, you all, I'm sure, already know, is the black part in the center of the eye. The iris as well, everybody knows, I think, is the colored part of the eye. The sclera is then the white part of the eye. And the cornea is actually an invisible part of the eye that is over top of the iris and the pupil. It's a transparent, very thin layer of epithelial tissue that overlies the iris and the pupil. It becomes important because if there is damage to that tissue, let's say you get an ulcer and the ulcer turns into a scar, and scars cannot be fixed, it may actually affect your vision because it overlies the pupil. And all vision all begins with light entering the pupil. But if you have damage to the cornea over the area of the pupil, then light will not enter that area and your vision will be affected. Sure. That central portion is covered by cornea, but the sclera, for example, is covered by conjunctiva. And not only... Okay, let's turn our attention to the eyelids, since we're in that area. We've already learned about the levator palpebrae superioris, that muscle that helps to raise the upper eyelid, and you've learned the orbicularis oculi, which helps to squint the eyes when it contracts. But let's look at some of the other structures here. The tarsal plates are kind of a tough connective tissue that also lies in the upper eyelid and the lower eyelid, and actually gives the eyelids its structure, keeps it from collapsing, gives it a bit of firmness. And then the subcutaneous tissue and skin will be laid over the top of that, and the muscle will be layered in there as well. So those are the tarsal plates. You see a top one in the gray and a bottom one there in the gray. There's also a lacrimal sac, a lacrimal, let's see down here, you can see the lacrimal sac, which will form some of the tears and store your tears. Then there's a nasolacrimal duct, which is not really shown well on this picture, but it goes from the medial aspect of the eye here, where the lacrimal sac is. You see that it's kind of hidden a little bit, but that area where the lacrimal sac is, there's then a duct that goes from there down into the nose. And that's interesting, because that's actually why, if you've ever noticed, when you start to tear, when your eyes start to water, you also start to sniff. Your nose gets wet. You feel like the snot is going to run out of your nose when you cry. This is why you're always blowing your nose when you cry. It's because the tears are going from the lacrimal gland up here, and they're coming down the eye and eventually being washed out in the lacrimal sac. And from the sac, of course, now if there's overflow, it falls out of your eye, right? And that's when tears fall. But a lot of it's going to be caught in that lacrimal sac, and then it's going to go through the nasolacrimal duct into the nose, and you're going to get rid of your tears through your nose. That's why you always have to blow your nose when you cry. Okay, then the last thing to talk about is the conjunctiva. This is another transparent layer of epithelial tissue, and it pretty much covers the rest of the eye and the eyelids that the cornea does not. So if we go back to the previous sclera, but actually the inside of the eyelids is also covered by conjunctiva. It's just a transparent layer of epithelial tissue. And so we call those two layers of conjunctiva different names. One is palpebral and one is bulbar. So the one that covers over the inside of the upper and lower eyelids, that's the palpebral. And the one that covers over the sclera, that's the bulbar conjunctiva. It's one continuous layer. There really isn't a separation. It's kind of artificial to separate it into two. It's all one continuous layer. But just so that we can talk about where the problem is it on the eyelid or is it on the eyeball itself, we separate it into palpebral and bulbar conjunctiva. Now, the conjunctiva is what gets inflamed in what we call pink eye. When somebody's eye gets kind of pink and they start getting some crusting around their eye, it's typically caused by a virus or allergies, rarely can be caused by bacteria. It's from inflammation of that layer that's normally transparent and see-through. It becomes inflamed and becomes red, or what we call pink. And so we give it the name pink eye. All right, so that's kind of what you can see on the outside of the eye. Now we're going to work our way back through the eye and see what are the other structures in that eyeball that we cannot see from the outside, from the surface. So let's just kind of work through from the front here, and this is going to be posterior here, so this would be anterior here. So let's kind of follow the course of light, and we'll see what structures it encounters. So light is going to have to come and pass through first the cornea, right? That's that transparent layer that overlies the pupil and the iris. and it's going to end up going through. The first thing it's going to enter is what we call the anterior chamber. The anterior chamber is the first place that light passes when it enters through the cornea before it hits the pupil. The anterior chamber is filled with aqueous humor. Sorry, that's something I just covered over with my circle, but that says aqueous humor. And it's a very liquidy, not very viscous, more like water, a little thicker than water, but more like water. And so light will pass through that, and then it will have to go through the pupil. The pupil is just the opening between the iris. Now, once the light goes through the pupil, it will hit the lens. And the lens will bend that light more or less depending on whether that light is close or far away. And it will cause the light to bend and then move into what we call the posterior cavity. And the posterior cavity is also filled with a fluid, but that fluid is much thicker. It's more like gelatin. It's more like jello. It's very gelatinous. And we call that the vitreous body. And you'll see when we're going to cut open an eye together this week in lab, and you'll see that posterior part of the eye, it's very thick. It's very jello-like, gelatin-like. And it's important because that vitreous body then gives shape to the eye. Because it's thick and a bit more stiff and springy, it helps the eye maintain its spherical shape. So it's important for that. Let's see if you can make out on this picture. So we have the anterior chamber we mentioned of the anterior cavity. There's also a very small posterior chamber here that's kind of behind the pupil. So in front of the pupil, you have the anterior chamber of the anterior cavity. And behind the pupil, you have the posterior chamber of the anterior cavity. And that's not to be confused with the posterior cavity. So try and keep those straight. Other structures you can see, we'll see some of these better on other pictures, but you do have the ciliary bodies, and you do have the ciliary zonules, these kind of strands that attach from the ciliary bodies to the lens, and we're going to see these better in a future picture. Those are going to be used to help focus light by either bending the lens or keeping it more flat. What else can we see here? I think those are the main structures really here. Okay, then finally on the back of the eye you have the retina, which is actually the special sense. It's where those, we've been talking about, for example, olfactory receptors, right? And we've been talking about sound receptors and position receptors and taste receptors. Well, the vision receptors, the special cells that actually receive light and turn that light into an electrical signal that goes to the brain for interpretation, those cells are in the retina on the back of the eye. Very thin layer back there. And again, we'll see this in lab when we cut open, I think it's a sheep eyeball. But on the back of the retina, we'll notice a few special structures. One is called the fovea. Technically, it's the fovea centralis, but often we just call it the fovea. This is the area on the back of the retina that has the highest concentration of cones, and cones give us our sharpest vision. And so the highest concentration of the receptors that give us our sharpest vision are all located in this one tiny dot on the back of the retina called the fovea or the fovea centralis. That is where we try to focus light. When we turn to an object and we focus on that object, what we're doing is we're directing the light that's bouncing off that object to the fovea centralis so that we can see it as sharply as possible. The rest of the retina will also receive light and transmit that to the brain as an electrical signal, but it won't be quite as sharp, quite as detailed. So the fovea is where the sharpest vision is. Now there's an area around the fovea called the macula, and I think maybe we'll see that on the next picture, where we also have fairly sharp vision, not quite as sharp as the center, the fovea, but it's still highly concentrated with cones, and we get good vision there. Okay, now notice there's a part on this retina right here where there actually are no vision receptors. There actually there's a disruption of the retina because the nerves that are coming from those visual receptors in the retina, they all coalesce and form the optic nerve. And where the optic nerve exits the eye and enters the skull, there's an absence of retinal tissue. So any light that comes through the eye and falls right there on the nerve, you actually can't see that because there's no receptors to receive those photons of light. So that's where our blind spot comes from. So the optic nerve actually causes our blind spot. And we'll see this better, I think, on an upcoming picture. Okay, if we want to talk about the muscles around the pupil, there's a dilator pupillae and there's a sphincter pupillae, and you don't really have to learn those names, but I do want you to understand the concept of constriction and dilation of the pupil. So the pupil is what's going to allow light to enter the eye. And so if you are in a situation where there is low light, let's say it's nighttime where it's just becoming dusk and the light is beginning to dim, or let's say you wake up in the middle of the night to go to the bathroom and the lights are off, there's very limited light available. So your eye will respond by dilating, by opening the pupil as large as possible to let as much light in as possible so that you can see as well as possible in low light. And that's very important. This is the reason why, for example, a lot of nocturnal animals, let's say owls or cats or some rodents, they're able to make their pupil very large and to allow more light to enter, so they're able to see better in low light than we are. Nevertheless, our eyes will dilate when the light is low to allow light to come in. However, let's say it's noon and you've been inside all day with the lights off in a lecture hall and you open the door and go outside, your eyes will immediately constrict because there is a ton of light outside. And actually, if you have too much light, you've all experienced this, you almost can't see because there's too much light, right? You get kind of a whiteout temporarily in your vision. And there's a physiological reason for that we'll talk about in physiology. But right now, just understand that in order to reduce the amount of light that enters your eye in those high light times of the day, your pupils will constrict and become smaller to hopefully allow a more manageable amount of light to enter. Okay, well, in order for your eyes to sense the amount of light that's coming in and then send a signal for either the dilator pupillae or the sphincter pupillae to constrict, you have to have a working cranial nerve 2 and a working cranial nerve 3. So cranial nerve 2 is going to sense the light, right? That's your optic nerve. And cranial nerve 3 is going to be the effector, the efferent nerve that's going to go and actually cause constriction of the muscle, contraction of the muscles. So this is why, for example, if you've ever noticed when you go see the doctor, he shines a light in your eye, what he's looking for is constriction of the pupil. And if I can find constriction of your pupil by shining a light in your eye, that tells me that both cranial nerve 2 and cranial nerve 3 are working, because they both have to be working to receive the light and to cause constriction of the muscles around the pupil. Okay, one other thing to know about pupillary constriction or dilation is that they are mediated by different parts of the autonomic nervous system. And we're going to talk later this week about the autonomic nervous system separately. But right now, just remember that the parasympathetic system is going to cause pupillary constriction. Let's see, reduced pupillary size. So parasympathetic is going to cause constriction. It constricts. And the sympathetic system is going to cause dilation. And I'll just tell you how I remember this if it's helpful to you. For me, we're going to learn, you probably already know this from, previous education, but the sympathetic part of the autonomic nervous system is the fight or flight part. And so if I'm getting ready to run away from a bear who's chasing me, I want probably maximum light to enter my eye so that I can see everything. My pupils are going to be wide-eyed and dilated, right, if I meet a bear in the woods. And so that's the sympathetic system, the fight or flight, is going to cause dilation. We'll see if that's helpful. Knowing the effects on parasympathetic and sympathetic system of certain drugs also helps us sometimes suspect those drugs by looking at somebody's pupils. So we will often look at pupil size on a patient who is unconscious or a patient maybe who's acting strangely to see if there may be particular drugs in their system that could be causing these symptoms. So opioids, for example, these are drugs that will activate the parasympathetic system and you'll get more smaller pupils, constricted pupils. Something like cocaine is a sympathetic activator and it would cause, for example, dilated pupils. All right, let's talk briefly about the lens. The lens functions basically to bend light to help us to focus the light that's coming off of an image. And the light that enters our eye is bent in two locations. First, it's bent in the cornea. And actually, 2/3 of the light bending occurs in the cornea. But we're not able to change the shape of our cornea. Now, we can actually a little bit by squinting our eyes. This is one of the reasons you squint your eyes. When you squint, you actually put pressure on the globe of the eyeball, and it changes the shape of that sphere, which actually changes the roundness of the cornea, and that actually changes the bending of light, the refraction of light. But in general, we're not able to affect the shape of our cornea very much. However, we are able to affect the shape of our lens, which does the last 1/3 of the bending of light. And the bending of light is important to get a sharp view of something. If we were not able to bend light, our vision would be very blurry. So by bending the light, we're able to focus the light on a particular spot on the back of our retina. And so we do that largely through our lens. So the lens is attached to some muscles that we call the ciliary body by these kind of strands, which we call ciliary zonules, are these kind of strands of connective tissue that join the ciliary muscle in the lens. And our brain will either constrict the ciliary body, contracting it, which kind of allows the lens to become more spherical, and that's important for near viewing. When we're looking at an object that's close to our eyes, helping the lens become more spherical makes that light bend more, and makes that object look sharper. And we'll talk about this more in physiology. We'll talk about how that works or why that works. If the ciliary muscles relax, that's going to make the lens more flat, and it's going to be better for distant viewing. And I already talked about the ciliary zonules there. Okay, I already talked a little bit about the aqueous and the vitreous humor. The aqueous is going to be in the anterior cavity. Remember, the anterior cavity has two parts, the anterior chamber and the posterior chamber, whether it's in front of, anterior to the pupil, or posterior to the pupil. Both of those compartments, however, have aqueous humor, and that's more like water, more like our cerebral spinal fluid. The posterior cavity I mentioned already has vitreous humor, which is more gelatinous and gives shape. Okay, here's a nice view of a retina. So if I take my ophthalmoscope and I look through your pupil, I can actually see back onto the retina, and I'll see a few things. I'll see lots of blood vessels, and all those blood vessels eventually end up around the optic nerve. And that's because they're going to exit with the nerve through the back of through the back of the orbit. And so they all kind of coalesce there at the nerve. So the nerve is going to be this yellow spot, this yellow circle on the back of the retina. So notice where all the orange and red is, that's where photoreceptors are. So there are no photoreceptors over the area of the optic nerve, and that's why we get our blind spot in that area. If you'll notice this area that's been kind of dotted out, that's the area of the macula. That's where your sharpest vision is. But the very center of the macula, the fovea centralis, that's the absolute sharpest point of vision. So when we turn our eyes to look at something, for example, right now I'm in a bedroom giving this lecture, and as I look at a outlet on the wall, I turn my head and eyes to focus on that outlet. That is taking the light bouncing off that outlet, and it's focusing that light on my fovea centralis so that I can see it as sharp as possible. And that's the very dark center of the macula. Now, light that's touching the rest of the retina is also creating electrical signals that will be sent to the brain. It's not as defined, it's not as clear as it is in the macula, and especially the fovea centralis. Rods and cones, I'll just bring these up because you'll have to know them when you get to physiology. Rods help us see black and white, and they are more numerous in the eye. And so they can help us see in the dark, for example, because there's not a lot of color visible in the dark. And they're the most numerous light receptors. But cones are the ones that help us see very sharp vision and help us to see color, but there's fewer of them. And so our body kind of uses both depending on what the light situation is. In low light, we're relying more on our rods, and in adequate lighting, we're gonna, especially when we focus on an object, we're gonna use our cones more. All right, so what happens to this signal? So as light comes into the eye, lands on the retina, and activates photoreceptors, these special epithelial cells that can respond to photons of light, those receptors will then trigger an electrical signal that eventually goes through the optic nerve out of the back of the eye. So there's the optic nerve. And those optic nerves crisscross at the optic chiasm. And that occurs, we've looked at already, right anterior to the sella turcica in the sphenoid bone, if you remember back from our bone chapter. They can crisscross right there. And the reason that they crisscross is that you want information from both eyes to end up going to both sides of the brain. So in truth, only half of the fibers crisscross. So part of the fibers, let's say this is the right eye here, and this is the left eye here. So this part of the left eye information stays on the left and goes to the left side of the brain. I'm sorry, we're talking about the right. This part of the right eye, these fibers stay on the right and go to the right side of the brain. But this part of the right eye information actually crosses over to the left, so the left brain also knows what the right eye is seeing. So this way, both sides of the brain, and the left side does the same, part of the fibers stay on the left and part of the fibers cross over to the right, so that each brain gets information from each eyeball. Now this is super important for us to have stereoscopic vision or binocular vision or depth perception. It might be another way we would talk about it. In order for us to see depth, we need to have information from both eyes going to both sides of the brain. And that occurs here at the optic chiasm. All right, well, we will look at the eyeball in class together when we meet on Friday for lab. And please bring any questions that you have from this lecture to that lab on Friday. See you then.